With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand, on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Hey, good morning, everyone, and welcome to UroNurse. Sorry about a couple minutes short to our start time, but hey, we're here. That's all that matters. And so welcome to the show. I'm Vic Senese. I'm the host of the show. If this is your first time joining us, be sure to check out our website at uronurse.com. Best place to learn more about the show. You can also download this on an audio version that comes out shortly afterwards. All the past episodes are there. Our sponsors are there, so you can go visit their websites. It's a great place to check us out. So let's get right to it. Today, we're joined by one of the world's leading experts in men's sexual health and Peyronie's disease, Landon Trost. Dr. Trost is a renowned urologist, researcher, and pioneer in advancing evidence-based care for Peyronie's. His work has shaped much of what we understand today about the condition, and he continues to lead innovation in diagnostic and treatment. In today's episode, Dr. Trost unveils the PeyroniesGene, a groundbreaking new step towards personalized men's sexual health testing. This emerging genetic approach has the potential to transform how we identify Peyronie's risk, understand disease progression, and tailor treatment to each individual man. Let's welcome Dr. Trost. Welcome.
Well, thank you, Vic. Thanks for having me, and thanks. It's good to be back with you. So you always run such a wonderful show and program, and it's certainly my pleasure and honor to be with you. So
yeah, well, thanks. You ready to get right into it?
Yeah, let's jump in. And
let's do it.
Timing wise, so I'm planning on, I'll run through these for maybe 20, 30 minutes, something along those lines, and then happy to take any questions you have at the end. So
perfect. I'm sure we'll have a few.
Okay, well, I'll just run through. So so for way of background, this is called PeyroniesGene, and I'll go into the background and history of it. It is one of those things that is a new area, and importantly, there are some important disclosures to kind of go over here. So I did contribute to the research of this concept and identification of the what are called SNPs, or single nucleotide peptides for it, that that isolate the gene. And I'm a part owner of Pathright Medical, which is held in a blind trust. So just keep in mind there is a high risk of bias there, because anytime someone develops something, they're always going to be biased towards it, and especially if they're a part owner in the company that licensed the technology, that that becomes potential risk of bias too. I'm also the president-elect of the Sexual Medicine Society of North America and the editor for the Journal of Sexual Medicine. And I do get research grants from endopharmaceuticals. There aren't any specific what are called PI funds, so I don't directly, take money from endo or anything along those lines, but I do have research grants. And I'm not speaking on behalf of any of those entities, but again, I just highlight the potential risk of bias anytime you are, developing something. So Peyronie's disease is actually a condition that's been around a very, very long time. This dates back to at least 3000 BC, where you can see on the bottom right there an example of a Minoan sculpture that demonstrates a penile curvature. This was specifically put in a temple of healing deities, where you'd basically create a sculpture of yourself of a condition. You put it in that temple, and then you'd get healed of that condition, was the thought. The earliest known recorded modern description is about 1561, and then 1743 it got its moniker with François Gigot de la Peyronie. So this is an old disease. It's been around for a very long time, and people have known about it for one degree or another. But interestingly, if you do a survey looking of urologists, and in this specific case, they looked at primary care physicians and urologists and said, well, how much do people actually know about this condition? And ask them various questions, and you can see 63% of primary care physicians felt that the prevalence of the condition was less than 1%, which is, it's far higher than that. 38% of urologists thought that it resolved in more than 50% of cases, and that's definitely not the case. Resolution is more like 15%, if even that. Does not occur in men under 40. You can see all these other questions that are asked here, but it shows there's quite a bit of misunderstanding and misinformation about the condition, even though it's been around for forever. Interestingly, now again, this was 2007, and I have a feeling the new commercials that have come out with bent carrot and things like that have probably changed this quite a bit. But unsure if medical treatment is available, 51% of primary care physicians, who usually will see this condition first before anyone else, are reporting that they're unsure if there's any treatment available. So it's very much a misunderstood condition. Now, part of that problem relates to definitions. Uh, Peyronie's disease has never been adequately defined in history. Essentially, anything that's a penile deformity is being called Peyronie's disease, and there's even some confusion with updated guidelines that may be coming out in the near future on this as well. So, just a couple examples. You can see if you have a 24-year-old who has a mild, gently sloping curve to the left, it's been present for 4 years. Now, take a 58-year-old with an overnight onset of curvature, no pain, and then compare that to a 48-year-old with a 100-degree curve with bad hourglass deformity and pain, and then a 63-year-old with worsening of the disease for 2 years, ongoing pain, and a big calcified plaque. Right now, all of these men would be considered the exact same condition, even though clearly these are very different conditions. The 24-year-old, that's not the same as this, overnight 100-degree curvatures and things like that. So,
Hey, Landon, I'm going to ask you if you could turn that stop sharing sign off.
oh yeah,
Usually there's
I
a
was
hide
curious
thing
if
you
you
can.
could see that. Let's do
Yeah,
that.
thanks.
Thanks for stopping me. I was curious. With these video things, you never fully know like what other people can and can't see. So, um, but yeah. So big problem here on the definitions, just because all these men would be classified similarly here. Now, when you to address this, last year we published a paper that involved a significant amount of work in trying to reclassify these, and we ran literally hundreds and hundreds of statistical checks just to see where correlations may exist, and looked through our database to try to identify if there were better categorizations. And we came up with this new nomenclature, which is basically the broad category of penile curvature encompasses Peyronie's disease, but it also encompasses non-Peyronie's conditions like congenital curvature, trauma-induced curvature, maturational curve, and these are different conditions. And then within Peyronie's disease, you've got different subtypes as well. You've got men who have a progressive type condition where it gets worse and worse over time or goes on for years. You've got relapsing and remitting, such as like with multiple sclerosis, where someone has the condition for a while, then they don't, then it comes back, or then it worsens. And then you've got calcifying, which is definitely a distinctive type of Peyronie's. And then you have classical that basically doesn't fall into any of those normal categories, which is the overnight curve, and it stabilizes and it's there and it's just present. And then on top of that, you can have a trauma component either here or here, because if you cut yourself, you get a scar. And if the penis gets injured, you get a scar. But that doesn't necessarily mean that it's Peyronie's disease. It could just be a normal scarring type condition. Now, when you look, and this is a busy slide that just shows that red means that it's different from other conditions. And so you can see when we categorized all these different subtypes, you get a lot of red popping up here. So a lot of statistically significant differences compared to men who don't have that subtype. And it basically highlights that these are indeed distinctive groupings. So we see these kind of diagnostic clusters, which demonstrate these distinct disease patterns. Now you say, well, who cares? That's good information and everything, but why do we care and why is this important at all? And part of the reason here is that the natural history of all these conditions is very, very different. If I go back a slide and look at this progressive versus classical versus calcifying and so on, all of these men are going to behave differently long term. So as a provider and as a patient, you want to know, well, what's going to happen to me? What kind of treatment should I use, and so on. And this information that now allows us to classify these men better goes a long ways to starting that process of providing better information. So when you look natural history wise, typically men with Peyronie's disease are going to present in their 50s and 60s. So the majority of people are going to kind of fall in that range. You do get some people down in their 20s, but it's not common. And most often these men are misclassified as something else, whereas the majority of Peyronie's disease will fall into here. And that's shown in these numbers. So mean age 45 to 59, age of presentation under 40 is only about 10%. So when patients come to see us in clinic, we will pre-screen all men under 40 just to make sure that they indeed do have either Peyronie's disease or something that we can for sure help them with. And it's important again, because how does this change over time? We did a survey, I don't think we ever published this one, but of men over about a 20-year period, trying to find out what the natural history of different conditions were. And you can see that there's quite the spread. So you get maybe 20-ish% that will say it resolved over time. Some will say it improved. Um, Many will say it just doesn't change at all. Some get worse and some get much worse. But this spread is different for each subtype of the condition. And so it's important to be able to differentiate that. Now, all of that is in the context that medicine has changed dramatically. We'll often joke when we hear about, the history of medicine, you hear about things in the 1600s, 1700s, and we always wonder, what did they do? If they're not doing blood tests or imaging studies and they don't have all these breakdowns of, the different therapeutics, um, how challenging was medicine in that day and what were they actually, doing with it? And if you look 200 years ago, honestly, it probably didn't even matter what illness you had because the treatments were all going to be about the same. You had willow bark, which is basically aspirin, purging, which is vomiting or laxatives, leeches, which was this imbalances of the humors, which is probably kind of talking more about the immune system, spa treatments, arsenic. You only had a handful of treatments that you were going to do. So there wasn't a lot of customization of medicine. Well, clearly today that's very, very different. You've got less and less intrusive ways of diagnostically looking at different areas of the body you can never look at before. You've got MRI scans that are getting incredibly detailed. You've got specialized blood testing. You've got DNA, genomics, other things there. You've got choline type scans and different things where you incorporate nuclear medicine type studies into scans, and it's just getting incredibly complex and amazing. What medicine can do today. Well, more and more genetics are playing a heavy role in that. This concept of personalized medicine is really growing. Everything from cancer treatments to the diagnostics themselves. We're getting more and more accurate diagnoses, better predictions of natural history, and most importantly, better selections of treatments based on that. And this graphic just shows that kind of concept that based on the DNA, you can say for this person, they get one treatment, this person gets a lower dose, this person gets double dose, this person shouldn't be treated at all, and so on. But that idea that we're integrating genetic testing into the overall algorithms of treatment is starting to be more and more recognized as a standard of care. Now, the end goal, of course, with genetics is this, wonderful success story, which is just brand new. So this was May 2025. CRISPR is an amazing technology where you're able to specifically alter the genes of someone or alter the DNA of someone. And if you can identify the genes that are associated with certain diseases or certain disease states, you can now go in and potentially cure that genetic condition. And I mean, that's absolutely incredible. And so it just emphasizes even more the importance of DNA and genetics in the overall process. Now, this specific headline was for this carbonoyl phosphate synthetase deficiency, and they were essentially able to cure that for the child in this case. So really incredible technology. Well, so if you say in 2025, November 22nd, 2025, how do you diagnose Peyronie's disease? Well, you feel it, or you look at a picture, and that's it. So it's not very um, specialized type medicine in that regard. It's not a matter of biopsies and diagnostics and things like that. So very, very base level, knowledge from a Peyronie's disease standpoint here. But again, not all curvature is Peyronie's disease. So you've got, these subgroups of Peyronie's disease, and even then we can't necessarily diagnose these except off of history. In this case, in the case of an ultrasound, we'd be able to do. But all of these ones, we can't really tell the difference. If we just look at a picture, we have a really difficult time differentiating trauma-induced from classical, from congenital, and so on. And same, if I feel someone with Peyronie's disease, sometimes you can't feel the plaque, but they clearly have Peyronie's disease. So even that isn't a perfect way of diagnosing this. So there's clearly a significant need for better diagnostics for Peyronie's disease. Now, people have been looking at this. So this is a wonderful study out of the University of Utah, 2022. And well before this study, Peyronie's disease has been recognized to have genetic origins. You see it run in families. You see it in people with what's called Dupuytren's contracture, which is essentially a contracture in the fingers that results in almost like a trigger finger type contraction. And there's clearly family lineages here. So these were taken from this 2022 study. And in this particular study, they showed that if you have a first degree relative, so brother, father, something like that, you're roughly sevenfold higher risk of having the condition yourself. Now, these start to fall out. The data starts to get pretty soft when you get out further. They did notice a difference here in fifth degree relatives and things like that. But but basically the concept is this is a familial type condition. It is passed into certain pedigrees. Well, so PeyroniesGene is basically the first commercially available genetic test that evaluates 4 genes associated with Peyronie's disease. Now, for background here, the way you get the sample is just simple. You don't have to do blood tests or anything like that. You basically just do a cheek swab, and with that cheek swab, you ship it in, and then we run the genetics of it to identify if you have a higher associated risk of Peyronie's disease or not. It does require a prescription, and many genetic tests actually do require a prescription because either FDA or historical ways of looking at this are uh, people often misunderstand how to interpret information. It's almost never that a genetic test can tell you that you absolutely 100% do have a condition or don't. Rather, it tells you your levels of risk, that you may be at an elevated risk of having it, or it can tell you things that are associated with it, like your higher risk of this being due to trauma and not necessarily being due to Peyronie's disease, for example. So it does require a prescription there. Um, Now, we are doing a big study on this to try to identify exactly what this can and can't tell you about things. We have about 400 men that are enrolled thus far, and it basically includes men who have Peyronie's and men who don't have Peyronie's, and these are confirmed cases of Peyronie's. And we did find 3 single nucleotide polymorphisms, which are SNPs, and with those, we're able to see the combination of those together that does correlate with multiple different areas of Peyronie's disease. So some of the data I'm going to show you now, it goes through what this test is able to identify and what it can't identify. Now with these, we were able to create different scoring systems. So we have a specific scoring system for Peyronie's disease, which discusses or which tries to identify how high of a risk you have of having Peyronie's disease if you have this combination of factors. And then also the response to certain treatments with this drug called Xiaflex, which is collagenase Clostridium histolyticum. That's the gold standard for treatment for Peyronie's disease right now. And so we created those scoring system as well to try to identify, can we help predict who does better or not, or who's associated with a better or worse outcome with these things. So overall, you can see this was our grouping of men. So the men in the Peyronie's group were 58 years old on average, whereas our healthy group was 39. And that's just because the healthy group we looked at, uh, when you get an older group overall, a lot of times they're seeing you for something else. So they may be seeing you for erectile dysfunction or low testosterone or something like that. We wanted a healthy group. And so we looked at men who were getting vasectomy reversals because they're coming in just to get a reversal. They're not coming in for any sort of medical condition. So it gives us a nice, good, healthy comparison group. And there's no reason to think people getting vasectomy reversals would cluster together higher or lower in one disease category. Now, among the Peyronie's men, on the median duration of the disease was 14 months, and this was the breakdown of those different subtypes. So classical was 44% of men, progressive was 54, 11% were calcified, either moderate or severe calcification, and about a third had a prior history of trauma of some sort. Curvatures were mostly up and to the side, either up only or up and to the side. You do see a small percentage that are pure side and some that are down. And then indentation hourglass, which is basically like narrowing, that was about half the population. And the median degree of curvature was 65 degrees overall. So these were, true Peyronie's men. Now, when you look at our scoring system, so men who scored a 5 were much higher or were much more highly associated with Peyronie's disease compared to men who had a 1. And then you have the split and breakdown there. Now, if you look at that, so men who had a 5 versus a 1 were basically 5 times higher likelihood of having true Peyronie's disease compared to not. Now, one caveat on this, whenever you do testing like this, it's tough because you don't know if that person 10 years from now is going to go on to develop Peyronie's disease. And so when we were doing these classification systems, we may find men who don't have Peyronie's but have a 5, but there's a decent chance that if we follow that person out to 10 years, they're going to end up developing Peyronie's disease. So that's the one challenge with these is we can't follow someone for their entire life history. And sometimes Peyronie's doesn't develop until you're 70 years old. So it gets to be tricky. Now, when you compare a 5 versus a 2, it's roughly a twofold increase. 5 versus a 4, it's only about a 1.3-fold increase. Now, another way of saying that is you have a 30% higher chance, 60% higher chance, 110% higher chance, and 480%, or maybe I'm saying this one wrong, 380% higher chance of getting the condition. So it just tells you your likelihood of having it there. Now, we always want to see, is it indeed a good predictor? So you can do these different things called rock analyses, or rock curves that help you decide, is this a good test or not? Now, basically anything zero point 0.8 and above is considered a good predictor, and in this case it was 0.8. And you can see, our table, or our scoring system does show up as being statistically correlated there. Now, there were some other interesting findings, though, from the studies overall, and this is where I'm kind of a data nerd. I love to look into these things and try to see what else correlates. And sure enough, we were able to correlate that if you had a 4 or a 5 on the scale, you had a 35% increased risk of reporting length loss. So blue here means that you are reporting length loss versus not. And so you can see that those who were on those higher scores, so this is if you're a 1 through 3, and this is if you're a 4 or a 5, you did have a higher rate of reporting length loss compared to if you had a lower score. Now, pain with Peyronie's disease, it was a 32% increased risk, depending on what score we have. And then there were select genetic variants at 100% rate of narrowing or indentation with the numbers that we have for it. So there are some areas of Peyronie's disease that we're getting to be very, very good about predicting that, if you have this genetic specific variant, you're very likely to have certain findings with Peyronie's disease. And again, that's very important, because if you get someone who has this genetic test, we're hoping that this will now allow you to be able to predict that, hey, you're at super high risk of developing narrowing or indentation, and hence we're going to alter your treatment paradigm a little bit, knowing that this is going to happen. We might put you on much more of a preventative course, knowing that you're likely going to have a progressive type condition compared to one where this is going to be stable forever, and we don't have to worry about it there. Now, interestingly, and this one to me is very interesting, because this is that score system again. So these are guys who had a 1, these are guys who had a 5. Blue is that you do have the finding or not. So this is the likelihood of prior trauma based on your Peyronie's disease score. So you can see men who have a 5 almost never report, or very low rate report trauma, than men who have a 1 or a 2 report trauma. Now, this is, again, real interesting to me, because this is saying that these might not be true Peyronie's men. These might just be curves that were caused by trauma and resulted in scarring. And again, that's important, because trauma-induced scarring likely behaves very differently compared to Peyronie's type scarring. Peyronie scarring is a hypertrophic scar, a scar that isn't healing like it normally should, but it's an over-aggressive healing, whereas these men are just healing normally like you'd expect them to. So this genetic test might be able to, for the first time, split that out to where we can say, you're a different group, and hence we're going to treat you differently, we're going to follow you differently, and so on, compared to this group. So time will tell on this. We need a lot more research to be able to externally validate a lot of this as well, but very, very interesting there. And again, if you look at 1 verse 2, verse 3, verse 5, it is statistically significant, and your relative risk is roughly 3-fold higher rate of having trauma there. And then again, if you look at how much of this is a predictor, so in this case, the area under the curve of the rock analysis shows that it's a fair, acceptable predictor in that regard. So basically it is viable. Once you start to get to like 0.5, it's just a completely useless test. And when you get higher and higher, the better of a test this is. All right, so now getting into the XIAFLEX prediction score. So XIAFLEX, again, is a drug that's used to treat Peyronie's disease, to treat curve. Here you can see men who, in this scoring system, 1, 2, and 3 are different scores depending on genetic variants. And you can see the men who had a 3 had a greater overall curve improvement compared to men who had a 1. Now, you always get outliers, like this guy's clearly an outlier, so we'd have to dig in and see what it is. Most likely in this specific case, we undermeasured the baseline curve type thing. But in any case, you can see that these are indeed correlated. So we can now, at least after the fact, correlate men who had certain genetic variants with the extent of improvement that they have. And again, that probably gets to the idea that these are probably different conditions. Someone who has a different score likely has a different type of Peyronie's compared to someone who has a different score, and hence it's going to respond differently to treatment. So now not only can we help identify different subtypes of Peyronie's better or different subtypes of penile curvature, but we can actually help identify who's going to do better with treatments versus not. So now it's becoming a very helpful test in that regard. So here you can see the median improvement was 50 degrees versus 40 versus 29, and it was statistically significant between the groups. So 3 in this case says, hey, if you have a 3, you're most likely to improve compared to someone who has a 1. Now there are several other correlations here that I can go into the different graphs and everything here, but we can find there's an association with the severity of calcification. Again, that's a different subtype. Where men who had 1s and 2s, we didn't find any that had calcification versus we saw 13% in the others. And again, this gets to the idea that these men are probably due to trauma. They're probably not Peyronie's, and they're probably not going to calcify ever. Collagenase, like we said, in that scoring system, we can identify men who have stronger nocturnal erections. Interestingly, though, it doesn't correlate with baseline curvature, length, or hourglass or indent as far as these predictive scores. So we do have ways of predicting this, like I mentioned, with other variables, but not these scores. Now that's interesting because that tells me, and this is based on other published series, that you can't look at these factors alone to predict who has different subtypes of the condition. In other words, just doing the existing diagnostics alone that we have cannot get to this information any other way. So this is a whole new set of information that promises to open up an entire area of research. And then interestingly, and we're just starting a new study on this, actually, it just got IRB approved yesterday, I believe, where we're looking at low testosterone symptoms and their correlations. In our data set, we indeed saw a bunch of symptoms that appeared to correlate pretty well with the genetic test. So erectile dysfunction, for example, they had a 70% higher risk with certain findings. Here's the specific breakdown here. We saw that you could correlate lower libido. So men who had one finding had a 1.5 lower point on libido on a score of 1 to 10. And then a bunch of low T symptoms. So decreased erections, as I mentioned there, as well as that other one I mentioned earlier about nocturnal erections. Self-reported depression was nearly twofold higher with certain findings. And the strongest of all the different predictors or associated findings related to memory and concentration. So we routinely ask people about this in our low testosterone questionnaires, but we found there was almost an 8-fold higher risk with a specific genetic variant. And even though I've run multiple what are called multivariate analyses, where you try to reduce confounders, get rid of age, get rid of Peyronie's, get rid of ED, all of these different factors, it still ends up remaining positive. So one of these days we might dig into this a little bit further and try to do a better test to see if this correlates with other real severe, mental health type conditions. Correlates with low libido, which is a low testosterone symptom, and weight gain and obesity also were strongly correlated with some of the findings we had. So, and what that means is these genetics that we're identifying are associated with multiple other things throughout the body, and hence it's not surprising that we're finding other correlations with this specific set of gene profile that we're looking at. Erectile dysfunction also is something that correlated. So if you compare 1 to 3 versus 4 to 5, you can see that nocturnal erections are definitely much stronger when you compare them against a partner. That's a good predictor for us on the impact that psychological factors will have with things. It's a good way of telling what probably your true erectile function without the psychological piece is, and we can see that it is correlating there. But it also correlates even when you just ask them, do you have erectile dysfunction versus not? There was a strong correlation there as well. So, overall, Peyronie's gene findings correlate with several sexual medicine areas, which include Peyronie's disease, the ability to predict the outcomes of collagenase, or at least to correlate the outcomes that someone had with collagenase, erectile dysfunction and symptoms there, and low testosterone symptoms. And again, like I mentioned earlier, there is a little bit of a challenge with that non-Peyronie's group because many of them may end up developing it at some point and they're just too early in their life to be able to tell, and hence it might be a false negative. Now that actually hurts our scoring more than helps it because it leads to more dirtier data in the control group, which if anything makes it harder to find these correlations. So if anything, it would only strengthen the findings we're finding even more. Now we do need to validate this with external series. We're actually just in the process of doing that now. We're enrolling another 200 to try to see if we can externally validate that through a whole separate cohort that we get to see if, again, you can prove these out further. So, but so far things are looking, very good with the 400 that we've enrolled. Okay, future plans. So again, like I mentioned, we are enrolling 200 more to validate it in a second cohort. We're doing that separate testosterone genetic study, specifically looking, can we predict who is more or less likely to respond to therapy? And does it actually correlate with low testosterone? Meaning that if you get a certain result on this, we need to check your testosterone as well, because you might have some other conditions. And then we're going to continue to try to identify other genetic targets, and specifically look at multi-gene families, epigenetics, and other areas there. So we're constantly always wanting to improve this to make it better and better with time. And with that, thank you for your time and look forward to the discussion.
All right, let's bring you on here. So yeah, that's a lot of information and a lot of new stuff. I'm going to bring in a question that I did see show up on the show here. So from Susie Swain, if your genetic test comes back high likelihood that you'll get PD, can they do anything to prevent it, or what would you counsel this patient on?
Yeah, good question. And that is a good question, even more broadly too, as far as what are all the potential roles and why would we get it and things like that. If you know someone's higher risk, and this is what we tell people who have, like, let's say you come in with Peyronie's disease, we'll say if you feel comfortable talking to your sons, brothers, things like that, you can pass along this information too. But if you catch it early enough, we do think there's a lot you can do to mitigate it and prevent it from becoming as bad as it would otherwise. There's a good study out of Spain from Martina Salamanca's group, where they started someone on traction very early, and they caught it within the first few months, and they ended up not having nearly as severe a disease if they didn't otherwise. There's also some data out of the UK, out of Ralph's group, that basically looks at if you start someone on Viagra in advance, and even potentially something like Clomid or tamoxifen, they're looking at these different drugs. You can also probably prevent certain cell types from turning into the final plaque that develops with Peyronie's. There's also some data that, to my knowledge, hasn't been published yet, but that shows that if you do ibuprofen, which is an anti-inflammatory, you can cut down the disease. And that makes good sense to me, because when you look at rheumatoid arthritis, ankylosing spondylitis, lupus, things like that, these DMARDs, or these disease-modifying antirheumatic drugs, are preventing the disease from developing and becoming as bad as it would. So there's every reason to think that would be true with Peyronie's disease as well. So if you knew that you were higher risk and you got the onset of symptoms, you could immediately start on a whole set of treatments that would probably, we think, would prevent you from becoming as bad as you would. So.
All right. Now the 5 classifications, 1, 2, 3, 4, 5, that's based on the genetic test. Not, it's similar. There's a 5-point classification based on exam too, right?
Yeah. So that one specifically, the genetic test. And so what it does is we basically looked at all the genetic profiles, and then we said, okay, which of these genetic profiles, you take all 3 SNPs, and then you say, hey, people with these SNPs, 100% of these men had Peyronie's in our cohort. And then we only include ones that we have at least 10 observations for, things like that. And then this group had 90%, this group had 80, and so on. And so then we created a scoring system that way. And then you take that and then you validate it in another cohort to say, okay, let's take a completely fresh cohort and see, does this correlate or not? And so we were able to look at that way to kind of create the scoring system. Now in Peyronie's, there's not a great classification system as far as scoring 1 to 10, 1 to 5, 1 to 3, or anything like that. Some people will say severe versus moderate versus mild, and even then that's troublesome, because there's not a universally agreed upon thing there, where someone may have 30 degrees but severe hourglass. Some would call that person severe, some would call them mild. So there's not a strong consensus in the Peyronie's community right now.
Yeah. And you made a point of that. This may lead us to being able to treat earlier when it's probably more simple to treat, because most of the patients, I'm sure, even in your field, are coming in with severe cases. I mean, people don't come in with a little bit of curvature because, let's face facts, us guys don't like to go to the doctor.
Well, and I think it for me, a lot of it is reassurance of it too. So for example, if someone comes in and they get a 1 or a 2 on the test, but they have bad curve, or they have a curve, for me, more and more, and this is how, looking at the data, I would counsel someone is to say, hey, there's actually a decent chance this is just due to trauma, that it's not the Peyronie's side of it, because people are very worried when they get a Peyronie's diagnosis, because it often means that the condition is going to worsen over time and that it's
Mhm.
going to lead to further deformity, and you're going to have higher risk of it recurring and having this progressive condition. But if you get a 1 or a 2 on that, that might just say, hey, this is just trauma. Trauma usually, like most scars, get thinner and smaller over time, and so
Mhm.
those are probably the guys that do get better and better as time goes on. So that's a very different mindset if you're thinking, hey, I've got a condition that was because of a scar and it's getting better over time, versus, oh, I
Hmm.
actually have this one I need to keep an eye on and I need to be aggressive with. And then family too. Do I need to warn siblings or other things about this?
Mhm.
Or my sibling has this. What's my risk? Did I also have a higher risk of this? Do I need to be, potentially worried about it? So I think all of those are potential areas where this type of information is good. And as everything in medicine, the more information the better. You just have to be real careful in interpreting it. You need to
Yeah.
realize that a 5 doesn't guarantee that you're going to get it, a 1 doesn't guarantee that you won't, and that's why you kind of take it in context of a discussion with a physician or a provider.
And on the provider side, how hard is this interpretation? I mean, is this something when you get the score back, it's pretty clear what to do, or is this something that you need a guy who specializes like yourself?
No, good question. And I should have put it in there now that you mention it, as far as what does the readout like on
Mhm.
this. And rather than just the score number, it basically gives you the interpretation of it. So it says, you are threefold higher likelihood of having Peyronie's versus not. And then there's a whole descriptive paragraph underneath it that goes into what were the data based off of and what does this mean. So it is meant to be for non-specialists to be able to interpret the results. And then it also gives an email address that the providers can specifically reach out to for questions on how to interpret, or if they have other questions as to what's the latest data and updates on it, because the data will continue to get more and more refined as time goes on, and so that information will always be in flux a little bit.
So you see this someday being like a screening test, like PSA is for prostate cancer. Somebody who's got a genetic history, their family has Peyronie's. Would this be something you might order on someone early on?
Maybe the challenge with the screening test is that you have to follow those people for a long time. So like the way to really know it would be, you get this screening test on people, and then those who get, say, a 5, you follow them for the next 10 years and figure out how many of them actually went on to develop Peyronie's disease. The problem there is that takes forever to do, and
Yeah.
numbers have to be huge. Like you need to enroll, 10,000 people and then follow them over an extended time. And that's in part why so few, predictive screening genetic tests really exist, just because it's so hard to find that. I think role wise, the way I would see it fitting in is it's one
Mhm.
aspect of the overall kind of diagnostic piece. And so you get the exam, you get the ultrasound, you get the genetic test, and then with that, it gives you a more holistic area. The other thing that really it would be on my shoulders to do is to pass this out to a whole bunch of other Peyronie's providers around the country and to say, see what you find with it and see if you can,
Mhm.
find similar genetic associations and what's the role and relevance there.
Yeah, and we're seeing this personalized medicine is a huge step. We're in the old days, everybody used what was working or what was the best options, but now we're able to kind of look at patients on a genetic background and say, hey, this is going to be the better route for you. So I
Mhm.
kind of like what you were saying. Maybe the medication would be different or the dose would be different based on this genetic test.
Yeah, and again, you can't, like, the test won't recommend that ever, just because genetic tests never
Mhm.
should do those types of recommendations. But that's where publications come into it, and that's where providers and medical providers say, hey, I use this test and here's how it changed what I do with it. Me personally, that's how I use it, is on the counseling side, to say,
Mhm.
hey, based on this, you're higher likelihood of having hourglass deformity, these types of things. On the treatment side, to say, based on our data, it looks like you're going to be more likely to respond to these therapies compared, or
Mhm.
less likely. And then also family counseling of, based on this, it looks like you're probably not true Peyronie's, but this may be due to a different condition altogether.
Now, if somebody they think they have Peyronie's and they want to get the test, you said it's by prescription only. So are they going to a urologist to get the test ordered, or can family doctors or nurse
Hmm.
practitioners order it?
Yeah, they can go to PeyroniesGene.com, and then on there's a downloadable prescription form that they would bring to their provider. The provider signs it, fills it out, and then the results go to the provider as well as to the patient. And so then the provider gets a faxed,
Hmm.
set of results so that they know how to interpret it. And then again, that's where they have the email address at the bottom, because the provider may say, I have no idea how to interpret this, or what to do with it. And so then they can consult with someone who can give them more information or background.
Yeah.
And then of course, as time goes on, usually new things take about 5 years for specialists to really get up to speed and up to date on things, and about 10 years for generalists.
Yep.
And so the more time that passes, the more that Peyronie specialists are going to know about this. And then even 10 years, we would expect general urologists to be more aware of it.
Yeah. Yeah. Um, as a test, is it covered now by insurance companies? Does Medicare cover it, or is out of
No,
pocket?
yeah,
And
in
if it's
fact,
out of pocket, how much is it about?
I think it's 200 or 250. I can't remember offhand
Mhm.
for sure. But yeah, Medicare, no insurances cover it. In fact, it's pretty rare for insurances to cover genetic tests overall,
Yeah.
because like I mentioned, none of the companies have done these predictive long-term type studies, and usually those are the requirements. In fact, most tests are not FDA approved for specific indications, anything like that. They're usually considered like lab-specific tests, and hence you have to have a prescription to be able to go over, things like
Mhm.
that. So,
Yeah, and typically that's what happens when you're on the cutting edge of everything. It
hmm
just takes a while before it becomes, gets into the insurance companies wanting to cover it and everything else. So it's
yeah.
really fantastic. I think that your personal venture through Peyronie's disease, all the things you come up with, these ideas, the way you think through it has really been a big plus for a disease state that I think most urologists treat, but have had little success early on until some of these things like Xiaflex came out.
No, thanks. Yeah, I appreciate it. It definitely helps when you see a lot of something, and when you really hyper specialize into an area, you just naturally start to notice patterns, and then you come up with things and say, okay, we need to, develop this or look into this further to find it, because certain diseases are quite advanced as far as like the science and the background and the amount of money
Mhm.
going into them to improve things. Some of the cancers are doing,
Oh, absolutely. Yeah.
HIV. I mean, you think of the innovations that have happened in HIV and hepatitis B and C and things like that, and it's quite dramatic, over the last 40 years. But when you look at Peyronie's, it's been 5,000 years, and there has been almost
And
nothing.
nothing, right.
Or I would say the last 10 years, maybe if you include Xiaflex, like 12 years, all of the innovations have happened in the past, decade. So
Yeah. Well, we got a large audience. Few people sending some comments thanking great information and thank you. I did see one I did want to bring up here. Um, are there men who should not undergo genetic testing for Peyronie's at this stage? Is there a reason you wouldn't want to do this test?
I think anxiety level is the tough thing. So there was a great lecture. I'm trying. Doug Carroll gave a great lecture. He's a wonderful geneticist. He's retired
Mhm.
now, but he was in the infertility space mostly. And he did a 23andMe test, and on the 23andMe test it said high likelihood of subfertility, high likelihood you'll never have children. If you do, they're going to have these malformations, different things like that. And then he popped up a picture of his 12 kids and said, I clearly don't have that problem. And just that concept that you always have to take every test with a grain of salt. And there are
Yeah.
some blood tests that are, if you have this, you have that condition. But there's far more where blood tests are kind of like okay, this raises our suspicion on, this condition or that. And so I think as long as you can take it in that context, that this is one piece of information I'm going to put in the broader
Mhm.
context, then wonderful, then that's great. But if you can't, if you know that I'm a real anxious person, I'm going to absolutely freak out if I get a 5, then you want to be real careful of that. And as an aside,
Yeah.
that's why FDA has been looking into this, because they consider some of these as high risk type tests. Because if you get
Mhm.
a genetic test back that says you're going to get pancreatic cancer and die in 6 months, they were seeing people who commit suicide or people who undergo treatments that they
Yeah.
should not be undergoing. And so you want to be real careful of that.
Yeah. Good point. Well, it's been a great discussion. I am going to bring up a little promo for next week's. Lori's been in the background because she'd got a pink eye this morning. Didn't want to
I
get on the
do, but I
phone.
am here.
Lori,
And
did you have
thank
any
you very much.
questions that you wanted to ask before I zipped
No,
off?
but I think that we touched base on the fact that, when I've been doing this for over 25 years, or in urology for over 25 years, and back when I first started, nobody came in with this, And it's just fascinating to see how much it's changed, like you said, probably in the last 10 years. And I know that it's hard for people to find specialists in this because,
Yeah.
we have one specific doctor that does it. I wouldn't say he's a specialist in it, but it comes to a point where we do Xiaflex, and then at that point, if that's not working, we have to refer them out. And it's really hard because there's a lot more patients with it now. And so it's really hard to find specialists. So I'm glad, that you're a specialist.
Yeah.
But yeah. But thank you. Thank you. It was a great talk.
No, I agree with what you're saying on it too, just because when you look at it, most sexual medicine practices see a lot of erectile dysfunction, low testosterone, things like that, but not a ton of Peyronie's. And if you don't see a lot of it, there's not a really incentive to hyper specialize in it and to really kind of, keep up on some of the latest. And so it doesn't make up a big portion of almost anyone's practice. It's real niche. And I think that's part why not a lot has happened over the last while. So.
Yeah, it'd be interesting to see how some of these studies come out with the low testosterone, because we know there's some studies that have shown that men now are having much lower testosterone levels than they have in the past. So who knows what that's going to bring about.
Yeah, I'll be curious. It's like I said, I'm a data nerd. It's fun to try to see what the puzzle shows, and then once you get the puzzle back, they're okay, I didn't expect that.
Yeah, fun to crunch those numbers, right?
Yeah.
Alrighty, next week.
Your bladder isn't as sterile as once believed. It contains a delicate community of bacteria known as the bladder microbiome. In this episode, I talk with urologic expert Todd Thompson about how this hidden ecosystem affects your urinary health. Learn how some bacteria help protect against urinary tract infections while others may contribute to incontinence, interstitial cystitis, and overactive bladder. We also cover new research linking the gut and bladder microbiomes, plus how antibiotics, probiotics, hydration, and daily habits influence this natural balance. Join us on November 29th at 9 a.m. Central Time to learn more.
Yeah, join us next week for that. Just like Landon is the expert in Peyronie's, Todd Thompson is the expert in these blocking catheters and bladder health as far as people with long-term catheterization, kind of the guru in it. So he's going to be talking, and he's been on the show before. Landon, hope you join us again in the future. We know you always have something new to talk about.
No, yeah, certainly it'd be my pleasure. And that's a cool intro. So strong work, Vic.
Yeah. Yeah, me and AI, we do a lot. All right, have a great weekend, everybody, and we'll see you next week.
So here's to the morning.